Hello, my name is Brian Jeong, and I'm excited to show you on behalf of my team the development of personalized control of hemodynamics, or PCH, for high-risk surgery patients. Blood pressure of high-risk surgery patients is one of the key vitals that needs to be controlled and maintained within an error range, typically above a mean arterial pressure of 65 milliliters of mercury. Short periods of low blood pressure have been linked with increased complications such as kidney injury and myocardial infarction, causing longer hospitalization and increased mortality. Kidney injury, for example, is associated with a six-fold increase in odds of death, 3-day increase in length of stay, as well as nearly $1 billion annually in increased hospital costs. Over 42 million patients undergo surgery in the United States each year. Of these cases, 5 million are categorized as high-risk operations, which involve procedures for patients with a mortality risk of greater than 5%. What's striking is that even though high-risk patients only account for 12% of all surgery patients, they account for 80% of postoperative deaths. A better blood pressure management system can substantially reduce the incidence of complications following surgery, especially benefiting this group of high-risk patients. Reducing perioperative complications with better blood pressure management not only improves postoperative course of high-risk patients, but also has a profound financial impact on both the hospital and the patient. Alleviating these costs of billions will allow hospital resources to be redirected into improving patient care and personal well-being. For the patient, better surgical outcomes and faster discharges will reduce treatment costs. This is data from the UCLA OR showing the blood pressure of a patient who underwent cardiac surgery. Giving medications to manage blood pressure in the OR is based on the doctor's knowledge of the medications and their experience. However, the management of blood pressure ultimately ends up being a matter of trial and error, resulting in unpredictable and poorly controlled blood pressure. The patient's blood pressure can spend a significant time outside of the target range, shown by each of these red squares. During these periods of several minutes, the patient's blood pressure dips below the safe limit, increasing the risk of poor outcomes. To solve this problem, we formed an interdisciplinary team of anesthesiologists and engineers at UCLA. Guided by the doctor's surgical and medical expertise, recently engineered solutions in precision medicine utilizing AI were applied to hemodynamics management and surgery and developed as PCH. The AI platform devised by one of our team members has been clinically validated for several applications, such as liver transplant immunosuppression, infectious disease treatment, and prostate cancer therapy. In developing PCH, our first step was to retroactively analyze data from cardiac surgery patients using the AI, which determined that the medications used to control blood pressure did not interact. This suggested that the platform could be used for a simple and effective control of blood pressure. From there, we moved on to preclinical studies in rats and filed a provisional patent in PCT application. The following diagram shows experimental setup and integration of the components. First, the rat was anesthetized with isoflurane and connected to a ventilator via tracheostomy. The blood pressure was measured with a pressure catheter, which streams the values to a computer. The PCH program then analyzes the data, recommends a dose, and controls the syringe pumps to administer the vasopressor or vasodilator. In our earlier iterations of PCH, we attempted to dose rats based on the population average sensitivity. This data shows that due to the rat's higher individual sensitivity to vasopressor, the dose given was too strong, the blood pressure overshot the target range. The population average dose of vasodilator was then administered, which landed in the target due to the rat's sensitivity to the vasodilator being similar to the population average. The improved version of PCH implements a dosing strategy which calibrates the sensitivity before injecting the full dose. In this method, a small calibrating dose is first given, and based on the dynamics of the immediate response, personalized sensitivity profile is calculated and used to determine the dose to target. By accounting for the subject's biochemistry and physiology at the moment of medication, PCH reduces overshoot and drug amount, minimizing stress on the patient's body. Here we have data from a proof of concept experiment that utilized dosing of medication with the latest version of PCH. After measuring the baseline blood pressure, the isoflurane concentration is increased to induce a blood pressure change. A partial dose is then given, and the program analyzes the change in blood pressure. Based on this change, the remaining dose is calculated and administered, which brought the blood pressure back into the baseline target range. Currently, PCH is patent pending and provisionally filed with the PCT. Continued animal research will focus on improving the algorithm and adding safety features to prepare the system for clinical trials. Following validations in humans, the system can enter a path to becoming a commercialized tool for doctors. The PCH system can create value for all stakeholders involved. For patients, better outcomes translate to faster discharge as well as decreased costs. For anesthesiologists, an automated recommendation system will reduce decision fatigue and free up attention for other tasks in surgery management. In ICUs, PCH can aid in stabilizing the highest risk patients and empower nurses to make quicker treatment decisions. Overall, PCH can benefit the healthcare system by lowering costs, and by also enhancing the doctor's performance. Incentives can be enabled, improving the quality of care. In summary, PCH gives personalized dosing recommendations for blood pressure control, an aspect of surgical patient management that can be significantly improved from the current standard of care. By dynamically accounting for the individual patient's sensitivity to medications with AI, PCH will be able to reliably assist in keeping the blood pressure within a desired range. We hope in the future, physicians will be able to utilize PCH to better manage blood pressure and advance healthcare. Thank you for your time and attention.